So not quite as jazzy as Child's Play, but most of us are women in the room. And of the men, I like to think some of you have some important women in your room. So my name's Quinn Russell. I'd like to start off with a few thank yous. I'd like to thank the team at Alberta Health Services that I worked with. They embraced me and shared so much knowledge with me and took every opportunity to take me on little field trips or to take notes or be part of groups. So that was quite valuable. The peers in the room, it's been a long couple of years for a lot of us, so we're almost there. And finally, I'd like to thank Sari. She was so supportive this semester, even putting up with me not being able to understand the time change between Calgary and Alberta ever for our meetings. I'll get there eventually, I'm sure. I completed my practicum as well with the Knowledge Translation and Evaluation team. This team works with 3 cancer screening programs and 2 newborn programs within Alberta Health Services. I was fortunate enough that the KTE team had a very specific project that could meet my timelines that they wanted done. So I worked with the breast cancer screening program. This program wanted additional information on a report that was already completed by the KTE team to increase, to provide interventions to increase the screening reads by radiologists of screening mammography. So I completed a literature review for that. So introduction and background. So it's been well established in published literature that breast cancer screening programs increase the success of early cancer detection. In the early 1990s, most provinces and territories established screening programs across Canada. However, an integral aspect to any screening program is to ensure the benefits outweigh the harms of screening. Abnormal call rates is one such harm. So an abnormal call rate in screening mammography is when an abnormality has been identified and the woman has to go for repeat screening or diagnostic tests. This can lead to additional tests and stress on the patients. Abnormal recall rates, unfortunately, often result in false positive rates. As you can see, there's national set targets of less than 10 for initial screens and less than 5% for subsequent screens. In Alberta, nationally, that target has never actually been met. Screening volume, like I said, a previous report was already completed. It was identified as one means to decrease an abnormal call rate for screening mammography. This is also recommended by the Canadian Partnership Against Cancer. So in this slide, you can see minimum required reads for Canada for radiologists reading screening mammography is 480. In other jurisdictions, it's quite higher. It's a minimum of 5,000 in most European and Australian countries. So there's a big discrepancy there. So the objective for my literature review was to synthesize current evidence from the literature on interventions to increase radiologists' annual reader volume. The methods that I did. So first, I created a PICO chart. My population was radiologists who read mammograms. Intervention was to increase volume of reads by radiologists. My comparison was no change to volume of reads. And the outcome was to increase reader volume with a decrease in recall rate. The settings that I pulled from were jurisdictions that reflected similarly to what Canada did, which was Canada, UK, Australia, and Western Europe, Scandinavian countries. Oops, I'm getting ahead of myself. So I did a literature search with the help of a librarian, which was extremely useful. We used 6 databases, Medline, Ovid, and Expo, Cochrane Database of Systematic Reviews, Cochrane Database of Central Register of Controlled Trials, Google Scholar, and PubMed. Screening of the literature took place only by me myself in 2 phases, title and abstract, and then a full text review. Data analysis, I used the quality assessment tool for quantitative studies. This is a Canadian tool, so that was advantageous for me. It used 6 different domains to analyze the data with rankings of strong, moderate, and weak, and is useful for several different study designs. Data was then synthesized into a report. So the results. So you can see I started out with 448 articles. Through inclusion and exclusion criteria, Of my 2 phases, I ended up with 9, which was much more manageable. Findings. So 2 strategies were apparent in the literature: a full-time dedication of radiologists to mammography screening and double reads, with 3 different double read options. Strategy 1, radiologist full-time dedication to mammography. This was the only study that directly increased reader volume. It's more reflective of the breast cancer screening programs in many other jurisdictions which have higher read volumes, and is also shown to decrease abnormal recall rate. Strategy 2, double read. So this was 2 radiologists reading every mammogram. Again, it was reflective of of programs in other jurisdictions, but was also found to increase the recall rate, which we were trying to bring down. Double reads using radiologists and computer-aided detection. This was found to increase recall rate, not really increase radiologist volume, and results were inconclusive due to the many variables. And finally, double reads using radiologists and radiographers. Again, increased recall rate and was highly variable in its conclusions. So, not supported within the literature was computer-aided detection and radiographer of double reads. Supported was full-time mammography radiologists and double reads. So what does this mean? Full-time screening of mammography radiologists directly increased reader volume, decreased abnormal recall rate, and was a cost-neutral option for the program. Radiologist double reads increased reader volume by increasing the amount of mammograms that have to be read within a jurisdiction, so it was an indirect increase. Unfortunately, increased recall rate as well as increase in costs. Limitations to this review. Little evidence actually exists that increase reader volume. Most of this literature included is from places that have radiologists reading greater than 5,000 mammograms. So transferability needs to be thought about. In Alberta, currently no radiologist reads greater than 5,000 mammograms. As well as due to the dates that I've included, there's a mixing of technology from film to digital technology that's used for mammograms. So what's next? I also completed a costing analysis on the 2 supported interventions. Both these reports were provided to the Alberta Breast Cancer Screening Program and presented to stakeholders, and hopefully this will leverage for policy change in Alberta for radiologists participating in screening mammograms, which will decrease abnormal recall rate in Alberta. And some of my lots of references, and that's it.
Thank you. Great presentation. Okay, questions from the audience. We have time for a couple.
I was so clear.
That clear.
No one knew.
It's amazing. Oh.
Well, hello, thank you for the presentation. It was really clear. I will assure you that. Amazing presentation. I just wanted to ask you a question, because you said that you've worked with 6 databases. And personally, for my work, I've only worked with 3, and that was too much to handle. So how did you manage all those 6 databases? Did you use any sort of referencing software, like maybe some tips on that?
Well, I probably would not have been able to handle that had I not worked with a librarian. And that probably, doing that database search took as much time as it did to review the 448 articles. We did a lot of gray literature search because we knew that that was possibly an option for us, so we wanted to include that in there. And we knew that it's a pretty direct, closed question, how to increase radiologist reader volume. So we wanted to cast a super wide net in hopes to get as much literature as possible. And as you can see, I whittled it down to 9 articles. And even that was a bit of a stretch. Like if I was being super specific, I probably would have only included 1 article. So I think all those databases was a hopes of getting as much literature as possible, but independently without using a or without using a librarian, I don't think that would have been achievable for me personally.
It always surprises me how long it takes to do a systematic review, the time it takes to go through the papers and apply the English.
Alberta Health Services, I know there's a couple people that did their practicums. There's generally a librarian affiliated with every
excellent.
program, which is very valuable, and they're
Such a big help.
way better at it than we are.
Oh, yeah. Yeah, definitely. Excellent. All right. You're off the hook.